topic is thoracolumbar spine trauma. So the aim of this presentation is we're going to learn the pathogenesis. I get it very short, don't worry about it, okay? But try to learn something at least. Okay? You're going to learn the classification system of the thoracolumbar fractures here. So this is my contents. So about the thoracolumbar fractures, we have some problems about the mechanical problems. So we have compression, we have dislocation and instability, and we have some neurological deficit, and if we can solve them, we have to prevent it, and if we can do it, we can recover them. So in the follow-up, we may have deformity and pain. So there are three types of classification system. The first one is Harris classification, as you know. The second one is AO classification system. AO is a good classification system. We have TRIX classification, and it has morphology about we have idea about the mechanism of the injury. We have neurological stature, and we have the posterior complex problem here. So this is the AO classification system. Please try to learn it at this session. A is compression, B is distraction, and C is the translation. And if you look close to it, and we also have modifiers for it, please look at A1. It's compression, it's bench compression fractures. A2 is split. We have fracture at both endplates. In A3, we have only fracture at one side. In A4, we have fracture in bilateral endplates. So please take care at B1. It's chance fracture. Maybe you will see it in an exam. They may ask you. In B2, it's you again have posterior tension band disruption. And B3 is the disruption, the hyperextension injury mechanisms, and we see especially in localizing spondylitis cases. And type C, please take care, it's translation. So, I don't know, I never summarized this classification system, but please take a photograph of that. There are lots of applications on the phones. And if you download this application, you can easily classify the AO and the TRIX classifications here. So the application is very easy. Just you select the AO classification here, then the system asks you the displacement tension band, or you have just select them, and it says that it's type B3. So if you follow up the charts that AO has published, you will see its works. So TRIX classification is a good classification system because it says that you have to operate that patient or not. So these three subtitles are very important. You again choose it from the application, and just in a few minutes you will learn if the patient needs a surgery or not. So this is the application again. You just select if the patient has a ligamentous complex injury or has a deficit, and you just choose the morphology of the fracture. Then it says 8. If the patient's score is greater than 5, you have to operate that patient. So the treatments are the treatments depend on to fracture, to surgeon, and according to patient. The fracture depends on the level of the fracture. The junctions are very important. So you see how many surgeon cents are inside the patient. This was a thoracolumbar junction fracture here. Pulmonary chest doctor, surgeon was there, and general surgeon was there. So if you have the team, you can do surgeries, combined surgeries like that. And patient-dependent factors are additional injuries, medical comorbidities, and osteoporosis. And surgical decision-making is you have the anterior and posterior approach. If if you do it from anterior, you can directly decompress it. You can add an anterior support then, and you will do a short segment surgery. And if you do it from posterior, it's indirect decompression. The levels are long, but it's more stronger. And we are familiar with this approach. This is a case example. This patient was 79 years old, has ankylosing spondylitis, has a car accident, has back pain. You see there is a disc rupture here, coming to the posterior part. So, when you see the images, this is the 3D. If you look at it, and if you apply the application, the score is 6. So, we need surgery, and what we have done here, this was a special case. Ankylosing spondylitis cases may need more longer lever arms, so you have to increase the segments here. So the thing that we have done here was we put intermediate screws. This intermediate screws means you insert screws in also in the fracture vertebra here, and we used double rows here. So take-home messages are: AO is a good classification system to determine the fractures. Use fixed classification. For surgery, if it's greater than 5, you need surgery. You have many options, but the main message here is do what you can do best. And I'd like to invite you to the Congress of Medical Spine Society. That's going to be held in September in Istanbul. This was my presentation. And yes, part A, B, C. Type C. There is a dislocation there, but look at the symptoms of the patient. The patient has no neurological deficit. So in these kind of cases, because of the rupture of the posterior longicular ligament, the patient makes own decompression. Because of that, the patient didn't have a neurological deficit. So what would you do in a case that has no neurological deficit? So we need a surgery. Right. Yes, what kind of surgery? Any answer? What we have done here, it says x264. We have done a posterior surgery. Thank you so much for your attention.